All right, so we talked about abnormal disorders, and so now we're looking at how do you treat those through therapy. The history of insane treatment, maltreatment of the insane throughout the ages was the result of irrational views. Many patients were subjected to strange, debilitating, downright dangerous treatments that were definitely not going to work. I think we talked about in class the idea that some people thought that mental disorders were because of people were inhibited with some type of spirits, and so there was a lot of work done to try to release those spirits. Pinel in France, and then Dorothy Dix, who may have come up in your U.S. history classes, founded the humane movements to care for the mentally sick. Therapy, it used to be that if someone exhibited abnormal behavior, they were institutionalized. You can see some pictures over there. Because of new drugs, better therapy, the U.S. is really in a policy of this deinstitutionalization, where most people are not institutionalized. We talked about this, but psychotherapy involves an emotionally charged, confiding interaction between a trained therapist and a mental patient. Biomedical therapy is going to use drugs, and then you have the eclectic approach, which uses these various forms of healing. When you look at the psychological therapies and we focus on psychotherapies, you're looking at theories such as psychoanalytic, the humanistic, behavioral, and cognitive, which are also all types of psychology as well. So psychoanalytics, Freud, you think about, I think this is the famous couch. This is what a lot of people think about when they do think about therapy, is laying down on the couch, tell me your feelings, tell me your thoughts, and that's Freud, that's psychoanalytic. Thinking about the deep, dark, what is causing you, driving you to think about these things or to act in a certain way. The aim, since psychological problems, the idea is that since they originate from childhood, repressed impulses, conflicts, the aim of psychoanalysts is to bring repressed feelings to this conscious awareness where the patient can deal with them, where energy devoted to id, ego, superego, conflicts is released, and the patient's then anxiety lessens. So you take what you are repressing and you make yourself aware of it, and then you can deal with it. Freud also used, you need to know that idea of free association to unravel the unconscious mind and its conflicts. So the patient would lay on the couch and speak their mind about whatever came to his or her mind. So for example, one of the things, if I said the color red, and then whatever the very, very first thought that came to your mind after I said red, he would take that and go with it. Or if I said school, whatever the word is, the idea of kind of free association, where does your mind go, just being able to talk. During free association, the patient edits his thoughts, resisting his or her feelings to express emotion. Such resistance becomes important in the analysis of conflict-driven anxiety. Eventually, the patient is going to open up and reveal his or her innermost private thoughts, developing positive or negative feelings. That's the idea of transference towards the therapist. So the process is free association, resistance, and then transference. So free association, you're making these connections with the word. Resistance is that you don't want to, you're hiding something, your repressed feelings, and so the resistance is part of this drive that's driving you. And then a lot of times you develop your positive or negative feelings towards the therapist because you transfer your own private thoughts to them. Criticisms of psychoanalytics are that it's hard to refute because it can't really be proven or disproven. And it takes a long time, and it can be very, very expensive as well. So the criticisms are, it's hard to really refute it because it's about what that person thinks or feels, and then also it's going to take a really long time, and it's very expensive because you have to go to multiple sessions. Psychodynamic, it's a little bit different than being a psychoanalytic. Influenced by Freud, it's in a face-to-face setting. Psychodynamic therapist understands symptoms and themes across important relationships in a patient's life. It's a type of interpersonal psychotherapy. It's a variation of psychodynamic therapy. It's effective in treating depression. It focuses on symptom relief here and now and not an overall personality change. So really there's very little difference, and most of the time they're clumped together between psychoanalytic and psychodynamic. And then the interpersonal psychotherapy is about, I just need relief right now. Like, I'm depressed, I can't go on another day, help me right now, rather than trying to change the entire personality. And then you have humanistic therapists that aim to boost self-fulfillment by helping people grow in self-awareness and self-acceptance. You have Carl Rogers, other people that are humanistic. Developed by Carl Rogers, the idea of person-centered therapy. The therapist listens to the needs of the patient and accepting, and they're very non-judgmental, addressing problems in a productive way, building his or her self-esteem up. But the idea of person-centered therapy, or a lot of times we call it client-centered therapy. The therapist engages in active listening. They echo, they restate, they clarify the patient's thinking, they acknowledge expressed feelings. A lot of times if I asked you what type of ice cream you liked, and then I'd say, and you said, I like strawberry ice cream, I would repeat back to you, oh, so you like strawberry ice cream. And it's really just to kind of help make sense of what jumbled thoughts may be and to hear them repeated back to you, to kind of clarify that you're on the same page, what you're saying is what you're really thinking, because sometimes we say words and it's not what we really feel or want. And then when somebody else says them to us, we want to rephrase it in a way that does make sense to us. So that's active listening. Behavior therapy is therapy that applies learning principles to the elimination of unwanted behaviors. It's a lot of times used to treat phobias or sexual disorders. Behaviorist therapists do not delve deeply below the surface looking for inner causes. They're really just trying to change your behavior on the surface. And a lot of times that can help because if you have like an addiction or if you have a phobia to something, learning to break that cycle, like not needing the cigarette anymore, the simple act, the behavior, people a lot of times who quit smoking will still reach for the places where they left their cigarettes at. That's a behavior thing. So learning different techniques, learning to break that is usually helpful. So you have counter conditioning. It's a procedure that conditions new responses to stimuli that trigger unwanted behavior. It's based on classical condition and includes things like exposure therapy, where you're exposed to the stimuli over and over and over again until you kind of get used to it. And then aversive conditioning, we talked about, where you pair the alcohol with something that might make you vomit and then or be nauseous, and then you start to pair those two things together and you don't want it anymore. And then you also have exposure therapy. So it exposes the patients to things they fear and avoid through repeated exposures, anxiety lessons, because they habituate to the things that they fear. Exposure therapy involves exposing people to fear-driving objects in real or even virtual environments. So it can be stimulated, and over time you're just exposed to that more and more. The systematic desensitization is a type of exposure therapy that associates a pleasant, relaxed state while gradually increasing anxiety triggering stimuli, commonly used to treat phobias. So you have a picture of a spider, then you might have a toy spider, then a dead spider, and then you move on to a live spider. And so slowly the idea is that you become used to that, whatever it is you're afraid of or whatever you have your phobia of. So a picture of a spider is much less threatening than an actual live spider. But by the time you see a live spider or touch a live spider, you have built up over time. Aversive conditioning, you can see it here, it's a type of counter conditioning that associates an unpleasant state with an unwanted behavior. The temporary conditioned aversion to alcohol has been reported, so you can actually learn to feel nauseous whenever you see alcohol. It's the same thing we talked about when we talked about conditioning. Operant conditioning is therapists use behavior modification. They're rewarded, and undesired behaviors are either unrewarded or they're punished. A number of withdrawn, uncommunicative 3-year-old autistic children have been successfully trained by giving and withdrawing reinforcements for desired and undesired behaviors. So whatever you want them to do, it's just like what we talked about earlier in the year. The idea that you are training them to get the behavior that you want. In a token economy, in institutional settings, therapists may create a token economy in which patients exchange a token for some sort of earned for exhibiting the desired behavior. A lot of times in Alcoholics Anonymous and AA, they have like tokens that you get after so many years of sobriety. Just so you're building those up, so you kind of have a visual representation, and then you can get different privileges for getting so many. You have cognitive therapy, which is training your brain to think in a different way. So if your normal reaction is, I lost my job, now I'm worthless, it's hopeless, and it ends in depression, how does a therapist work with you to retrain your brain so that when you lose your job, you're like, well, my boss is a jerk and I deserve something better, and you don't end up depressed. So that there's this assumption that thoughts intervene between events and our emotional reactions. Aaron Beck suggests that depressed patients believe that they can never be happy, and thus associate minor failings like failing a test in life as a major cause for their depression. And Beck believes that cognitions such as I can never be happy need to change in order for depressed patients to recover. And so it's about, how do I change that line of thinking? How do I change their mind from I can never be happy to I am happy? And the change, he says, Aaron Beck says, is brought about by gently questioning patients. So Rabin trained depressed patients to record positive events every day and relate how they contributed to these events. And then he compared those to other depressed patients, and trained patients show lower depression scores. So Rabin, the idea is he had, if you were depressed, every time something good happened to you, positive happened to you, you wrote it down, but not only did you write it down, you wrote what part you took in that positive event. Menchenbaum trained people to restructure their thinking in stressful situations. So relax, the exam may be hard, but it will be hard for everyone else too. I studied harder than most people. Besides, I don't need a perfect score to get a good grade. And so the idea is you go from thinking, like, if I fail this test, my entire life is ruined, to, I studied, I'm prepared, and even if I don't get the grade I want to get, I can still succeed in life. And so taking a deep breath and being able to do that, the stress inoculation training. Cognitive therapists often combine the reversal of self-defeated thinking with efforts to modify behavior, and that's called cognitive behavior therapy. So cognitive theory is about the way you train your brain. Cognitive behavior is combining that conditioning aspect with also the way that you're thinking. And then you have group therapy, which is normally consists of 6 to 9 people. One of the main benefits between that is that it costs much less than if you are in a therapy session by one-on-one. So clients benefit from knowing others have similar problems. Usually they're about 90-minute sessions, so they can help for more people, and it also costs less. So that's an advantage to group therapy sessions. Family therapy, it treats the family as a system. Therapy guides family members towards positive relationships and improved communication. The thing that you have to make sure of in family therapy, though, is that everyone is on the same page. Everybody shows up, everybody is actively taking part, and so it's a family system. The therapy guides family members towards these positive relationships, improved communication. It can be very helpful, but everybody has to be on board with it. And a lot of times family therapy and group therapy are combined with individual therapy and rehabilitation centers and things like that. So evaluating therapies, who do people turn to for help? 41% of people turn to physicians, 38% to mental health specialists, and then you also have people like the clergy that about 20% of people go to for help. Psychotherapies, you can see here within psychotherapies, cognitive therapies are most widely used. The idea that you're learning to retrain your brain. And that's followed by then psychoanalytic and group therapy. Is psychotherapy effective? It's difficult to gauge the effectiveness of psychotherapy because there are different levels upon which its effectiveness can be measured. So does the patient sense improvement? Does the therapist feel the patient has improved? And how do friends and family feel about patient's improvement? Those are the things you have to ask yourself when you're thinking about, is this effective? Does the patient see improvement? Does the therapist see improvement? And do friends and family see improvement? If you ask a client about their experiences of getting into therapy, they often overestimate it. Client enter therapy in crisis, but crisis sometimes subsides. Clients may need